Hi everyone, this is Group 14's project on osteoporosis for FMPH 161, the class Clinical Nutrition for the winter quarter 2022. The group consists of Dianne, myself, Isabel, Emily, Briana, and Katelyn. Let's get started. Here's a rundown of our presentation for today. First, we'll introduce osteoporosis, associated symptoms, and comorbidities of the disease. Secondly, we'll cite the prevalence of osteoporosis in America, the impact of osteoporosis on the healthcare system, and at-risk populations. Third, we'll identify target populations for the osteoporosis interventions of this project today. Fourth, we'll present and evaluate past and current interventions that address osteoporosis in the populations. And finally, we're going to suggest next steps for osteoporosis treatment and possible revisions or replacements of current interventions. The term osteoporosis describes porous, low-density bones, which result when the rate of bone growth can't keep up with the rate at which calcium is metabolizing out of the bones at a cellular level, leading to weaker, more fragile bones. This is especially disastrous for elderly patients who are on average more prone to falls, fractures, and bodily weakness. In the US, it's the elderly and postmenopausal women most at risk for developing osteoporosis, with elderly Asian American women at the top of that list. Our group would like to focus on decreasing the prevalence of osteoporosis in the US by focusing especially on behavior change and the provision of screening procedures. So that means we'll be focusing on a younger Asian American adult women population in California. The changes we're looking at are in bold below.
Our target population is Asian American women from 25 to 65 years of age who reside in California. Asian American women are found to have the lowest bone mineral density compared to other ethnic groups. In fact, 20% of Asian women aged 50 and older have osteoporosis, which is 4 times more than Black women and 2 times more than Hispanic women. Additionally, with osteoporosis comes other health effects, such as multiple bone fractures. Once they have one fracture, they are at risk of getting another fracture, which can add to the existing symptoms such as chronic pain, a decline in mobility, and increased mortality. Economically, the U.S. spent $17 million on 2 million fractures alone, and is projected to increase significantly over the next 50 years.
One intervention meant to decrease the risk of osteoporosis among Asian Americans, specifically Chinese American women, was an interactive 6-week health education nutrition program based on the theory of planned behavior. Visual demonstration lessons were tailored to address the factors of attitude toward consumption, social influences, and perceived behavioral control over consumption, using assessment forms requiring subjects to self-score their calcium and vitamin D intake following food label reading activities, recipe preparation and tasting, take-home activities, lessons on how to read the nutrition facts label, and opportunities for family members to taste the recipes they learned from these classes. This motivated participants to adopt a more calcium-rich diet and decrease their risk of developing osteoporosis over time after changing their diets. In regards to the past intervention I just spoke about, I believe that this intervention should continue because it effectively corrected the misconception that vitamin C and D supplements are the main source for decreasing one's risk of osteoporosis. It also led to sustainable changes in behavior. It's important to reinforce the idea that supplements and meals rich in calcium should go hand in hand in order to decrease one's risk of osteoporosis. Consuming supplements and a calcium-rich diet together can maximize efforts to decrease your risk of osteoporosis.
Q-Fracture is a screening tool recommended for people above the age of 40 and below the age of 65. It uses a prediction algorithm to estimate the observed risk of osteoporotic fracture and hip fracture for men and women separately using variance estimates. This also accounts for the incidence rates of osteoporosis by ethnic origin, which addresses the current evidence of healthcare disparities in screening and treating osteoporosis between different ethnic groups. Since Q-Fracture estimates an annual risk and takes into account a wide range of CRFs, it allows for early detection and diagnosis of osteoporosis and can therefore assist in treatments to mitigate pre-existing symptoms and decrease the risk of developing osteoporosis. While Q-Fracture does address a concern for some healthcare disparities in relation to ethnicity, it is not calibrated to the epidemiology of other countries and does not accommodate the inclusion of bone mineral density. I would suggest for Q-Fracture to account for these discrepancies in order to be more accurate, reliable, and to be able to be used in a worldwide scale.
Similar to the Q fracture, FRAX is a more accurate assessment currently used to gauge the 10-year probability risk of hip and other major fractures for those over age 40. Any patients with a FRAX calculated risk over 8.4% would be recommended for a DEXA scan and further treatment. DEXA is currently the most accurate and sensitive test, typically suggested for patients over age 65 but can be used for younger individuals. It measures bone density at the spine, hip, or total body and can also measure body composition. Frax and DEXA are both interventions that should be continued because they can detect osteoporosis to prevent fractures. Frax is not as accurate as DEXA because it's not a scan and because it does not account for history of falling, recent fractures, and multiple osteoporosis-related fractures. However, it is more affordable and easily accessible. Healthcare providers should therefore recommend and implement more use of the FRAX assessment starting from age 25 for Asian American women, which is the population at most risk. DEXA scans should be utilized for this same population starting from age 40 because of increased risk of disease development for those beginning menopause, during, and after.
Here's a list of all the references used in creating this presentation. Thanks so much for listening. Stay safe and healthy out there, y'all.